Alrighty, so this is just a quick little highlight on the beginning physical assessment PowerPoint and lecture that we did. So going back over there again is just knowing that that front page of that assessment that you're going to do, that incorporates the introduction and that incorporates what we call that general inspection or general survey. So that is really that meat of walking in with that inspection portion, because again, I can look and see somebody's, you're addressing like their personal hygiene, you're addressing how are they responding to you, that mood, affect, their speech, is it clear, can they hear you at a conversational level, are they alert, are they oriented? What is their body structure, position, environment, their mental, emotional, behavioral status? All right, and so and then what all that kind of means to us, because again, we talked about it's not just always physical, it can be that behavioral or mental status change, emotional aspect, because maybe they were in a trauma situation or a domestic violence situation. You have a homeless client coming in and things like that. With health assessment, so there's three parts with that health assessment. There is the nursing history via interview. So I'm talking to my patient, I'm talking to their family member, and we're asking questions to gather data. You have the behavioral assessment, which is really kind of observed more during your talking and your communication process with your patient, and then our hands-on physical exam portion. I mentioned a little bit about the nursing process, which we call ADPI, assessment, diagnosis, planning, intervention, or implementation, and evaluation. So with assessment, again, this is the portion at the very beginning, right? That's got to be step one, and that's that inspection. It is that palpation, that auscultation, your subjective, your objective. That's everything. All your data gathering comes to that. Again, then with nursing diagnosis, it's not a medical diagnosis. It's a problem kind of diagnosis that's specific with nursing. So if somebody was having, let's say, that they were having shortness of breath, a nursing diagnosis may be altered respiratory status, or I'm going to go back to skin breakdown. So somebody does have already a stage 1, your nursing diagnosis may be impaired skin integrity related to skin breakdown as evidenced by non-blanchable erythema on the coccyx area or something like that. That will fall more into place really when you get to more into 117. They really go into the whole ADPI, but I'm just trying to give you a little blurb about it. So nursing diagnoses, you should have a nursing NANDA handbook on that you will use throughout the program. And then planning, again, is your planning is going to stem off of your assessment and your nursing diagnosis. Each one of these just kind of build upon each other. So like I said, if I've noticed in my nursing diagnosis is this impaired skin integrity, because they already have a stage 1, I want to put some kind of plan into place to prevent that skin from breaking down further. So this is where I'm planning. What can I do for that patient? Well, I know that turning and repositioning a patient every 2 hours will help. I know that keeping a patient clean and dry will help, so especially if they're incontinent. I know that trying to encourage good nutrition and fluids will help. So I'm kind of planning things that can be done to help with that patient's skin integrity. Implementation is the action part of your plan. Now you're actually putting that into play. So that is, the patient was turned and repositioned. The patient was provided peri-care or personal hygiene care after incontinent episodes. And then the evaluation, again, is there's always like a time frame of when you want to accomplish a goal. And the goal, or like when you identified back in the planning, hey, this patient has a stage 1. I want to prevent this patient from having any further skin breakdown by the time they're discharged. So on the day of them being discharged, you go to that evaluation portion and you're looking to see if that goal was met or not met. And so if that skin stayed about the same and did not get any worse, you really met the goal. But if the area of skin breakdown did worsen, the goal was not met. So you're just really evaluating the planning and the interventions that you did during the patient's stay. Okay. So again, it's in the nursing history part of assessment that you are going to get all of the subjective and objective. And one way, guys, to maybe memorize too for the subjective is what the patient says, or if you're reading like documentation, if somebody says something, it should be in quotes. So when you're thinking about it, it's like what they say in quotes, or what that patient says to you. Again, maybe it's a family member or a friend that brings them in. So it's what that patient tells you. Objective is you as a nurse, what can you measure, what can you see, what can you physically observe with your own eyes, okay? So please make sure you go over that again. Just again, some types of questions. We talked about the importance of that, open-ended versus closed-ended. Yes, we're going to need probably typically more we want to ask open-ended questions, but there are times that we just do need maybe a yes or no, or point to the area kind of situation. So go back over those two, what they entail. We talked about ways to kind of collect the data as far as making sure that you do actively listen to your patient. Don't be disengaged. Facilitating, so just trying to get them to talk and to open up unless they're medically unstable. And then also make sure that you clarify or restate, and to make sure that you adequately understand what the patient's trying to tell you, or summarize up. Be very cognizant about not being confrontational in the tone of your voice, and then just the interpretation of making sure, again, can you repeat what they said and make sure it's the correct interpretation if that is needed. Okay, for the purposes of physical examination, again, we just talked about we need to get baseline data health, patient's health, and we talked about why is it so important for baseline, because I need to know if it is a change or variation. Okay, it supports our nursing process. Think about priority patients again. We talked about ABC quite a bit today, airway, breathing, circulation. So really it's that, if somebody has that compromised airway, obviously they're not going to be able to breathe. And if I don't get to that patient first, they're going to, be in a medical emergency. They got an airway, but there's something with the breathing. They have an airway breathing, but there's something with the circulation. So kind of keep that in mind. And then again with that OCARTS, especially when it comes to the pain assessment. With documentation, we just talk about, again, if it's not charted, it didn't happen. So your documentation, make sure it's complete, accurate and descriptive. Types of assessments. Just again, comprehensive is all inclusive. It's a very detailed, problem-based, focused is just what is that patient kind of coming in for, and then expanding upon that specific. Cultural sensitivity, again, the biggest thing with this is avoiding stereotyping, avoiding gender bias. We are always culturally sensitive and provide the appropriate care based on the information that's gathered with your patient. And so absolutely, as someone had asked today, is it appropriate to ask a patient what values, what beliefs, what practices can I be respectful of, and again, tie in the religious and spiritual aspect. Absolutely, because we do want to support every patient. We are all individualized patients, or, if you're in the hospital, and want to be respectful of everybody's wishes as much as possible. We said culture is really social beliefs, values, and norms. It is different than ethnicity. Again, different with religion is more narrow, more of an organized systems of beliefs and rituals, where spirituality is a broader concept. And we do know that spirituality and religious beliefs can be a huge impact on a patient's healing. And again, if they, want time to pray before going to surgery, or ask to see a chaplain, or ask if their pastor can come in, these are things that the hospital absolutely will provide. Okay. Again, just read back over about culturally sensitive care tips. And again, I think the biggest thing is not stereotyping and the bias. When we talk about preparation for an exam, and we said, you know what's the first thing as far as infection control? So it's that hand hygiene that you should be performing prior to touching your patient and upon exiting the examination room. With environment, you need good lighting to examine your patient's climate control, because you know what, if a patient's really, and hospital rooms are so hard to regulate, I think, so if it's really, really cold in there, they may be shivering and then they're uncomfortable, or if it's really hot, right? Making sure that we clean equipment in between patient use. So like you're going to clean up your stethoscope before you'd move on to the next patient. We talked about standardized precautions. So that's generally the use of gloves and then any PPE that is necessary. Okay. We talk about the organization of your examination. We said you're going to do a cephalocado approach. So, I mean, you're going to start from the head to the toe. And we do a symmetric, so side to side, symmetric, organized head to toe approach. Okay. Again, going back to techniques of physical assessment, inspection, number one, then palpation, percussion, which is the portion that you won't do, and then auscultation. So with inspection, again, thinking of your eyes, your sense of smell, you can, palpation is with touch, and auscultation is what you're going to be able to hear. Okay, so when we're listening to bowel sounds, when we're listening to those lungs. And with palpation, we do not do deep. It is always light, about 1 centimeter, like a ½ inch or something like that. Inspection, again, going back to adequate lighting, using direct lighting when you're inspecting body cavities, checking for symmetry, position exposed body parts as needed so that all surfaces can be viewed, but you're absolutely maintaining privacy along the way. Using different parts of the hand when it comes to palpation. So like I said, for the back of the hands or the dorsum to feel for temperature, using the fingertips when you're checking like pulses, using more of the bony part of the palm of the hand. If you were checking for like vibrations on a patient's when they speak or something, that kind of helps to pick up different type of fluid buildup, but you're not checking vibrations. It's just a reminder that you will use different parts of the hands. Okay, let's see. Again, with the auscultation, you're listening with your stethoscopes, and also remembering that you will want to check your patient to the best of your ability on their bare skin, not over their clothing, because you can get artifactual noise. Positioning, make sure you look at your different positions, but again, I know you get into that at 117, but it's just keep it in mind is that generally most of your patients you will use the supine, the sitting, or the side lying. And again, it's assessing that patient, because not everybody can lie on their side, not everybody can lay totally flat, which is your supine. Some patients can maybe only minimally sit up on the side of the bed because they're too weak, or maybe they're dizzy and they're not safe to sit on the side of the bed. We talked about pain being the 5th vital sign, and so again, you need to get in there and read a little bit more about the pain, because again, people who are in pain, it can affect the whole body. We talked about how, you know, it affects oxygenation, it affects for their nutrition, elimination, how all these things can you know stem off of a certain concept or this problem that a patient is having. And so when you look at pain, we said the nurses have an extremely important role in managing a patient's pain, and just be very influential in how the patient pain is managed, and we need to really try to provide pain relief. You'll hear us talk about pharmacological versus non-pharmacological, because we don't always want to jump right to pain medicine. If it is just something that maybe, again, they just need to be turned in position, maybe they need to be assisted to sit up in the chair for a little bit because they've been in bed all day. You're utilizing your pain scale, and you have to assess, and this is really where that old carts come in. You are assessing. So if a patient tells you that they're in pain, what are you doing? You have to ask more questions to get to the root of the pain itself. Again, onset, location. So you're just as general that you are asking questions. And then if it is time for them to have pain, and that is or have pain medication, after you've asked your questions and assessed them, then you can get the pain medication if it's time for it. Again, if you're giving an injection, whether it's through the IV or whether it's an injection into the muscle or whatever, you're going to reassess with them within 30 minutes. If it's an oral, it's going to take longer. So you would reassess that patient within an hour if it's an oral pain medication. And you must document, again, before and after in your patient's chart. With pain types, again, you can have acute, which is generally less than 6 months, and it does end with healing. Our example was like maybe a surgery, right? You're in pain for a few days, or maybe a little bit longer, but eventually that surgical incision will heal and you should be up and good to go. Chronic or persistent is intermittent or continuous, and that is lasting more than 6 months. Things like that can be those like herniated disc, arthritis, right, is a lifelong battle. Referred pain, again, is felt in an area away from the area of injury or disease. And then phantom pain is that pain in an amputated limb, because the brain will tell that patient for a while that that limb is still there. Everybody has a different tolerance, pain tolerance, and we talk more about this in your pharmacological class about tolerance and dependence and things like that. Okay. So we talked about OCARS. Again, the pain assessment was from 0 to 10, with 0 being the least or no pain, 10 being the worst. We always are trying to get that scale done, because the thing is if somebody tells me that they have a 10 in pain and I give them pain medication and I know I have to go back and reassess, one of the things I'm going to say again, okay, now on a scale from 0 to 10, 0 being no pain, 10 being the worst, where is your pain at now? And what should be our goal? We should see that if they were at a 10 prior to that pain medicine, hopefully they're going to give you a lesser number. Hopefully it's going to be, maybe it'll be 7, 6, or even lower than that. There are some things that maybe I can never get the pain to be at a 0, but a lot of times we can at least get it down into the lower number, maybe 3, maybe 2, right? So if they were up at a 10 and now they're like, oh, it's only maybe like a 3, that's a great improvement. That's a great response to that pain medication, okay? All right, so I really think that's it. I think just go back again over the PowerPoints, the notes, and do your readings, and you should be all set to go.